Hello, good afternoon, and welcome to today's webinar on ACEs Aware Request for Proposal on Provider Training, Engagement, and Communications. We're going to start with a quick sound check. So if you can hear me all right, please raise your hand. Great, it looks like we're coming in loud and clear, so that's fantastic. My name is Hillary Haycock. I am with Harbage Consulting, and we are really delighted to be working on the ACEs Aware project. If we run into technical difficulties this afternoon, please just log back into the webinar, dial back in using the same number, and we will get started again as soon as we can. And just to start us off, we will be posting the slides in this recording to the acesaware.org website next week. So if you are going to be looking for the slides, they will be posted next week. Let's go on and review our agenda. All right, so we're going to start with welcome introductions. Today I am joined by California's first Surgeon General, Dr. Nadine Burke-Harris, as well as the Department of Healthcare Services Medical Director, Dr. Karen Mark, as well as Dr. Edward Mochtinger, who is working who's a professor at UCSF and is going to be working with us on the California ACEs Learning and Quality Improvement Collaborative. So today we are going to provide you a brief overview of the ACEs Aware Provider Training and Engagement Initiative. We are going to review the draft request for proposal. We are going to then have a discussion with the Surgeon General's Trauma-Informed Primary Care Implementation Advisory Committee. And then we're going to follow that with some public comment Q&A, and then we're going to get an update from Dr. Mochtinger on calQIC. So let's start off with just to give you guys a little bit of context for the draft RFP that we're releasing about what we're doing overall and the ACEs Aware Provider Training and Engagement work. So we are so excited to have launched just last week Phase 1 of ACEs Aware, which is a 2-hour online training providing sort of that minimum training requirement for Medi-Cal providers to be reimbursed to provide ACEs screenings. The training covers the basics of what billing providers need to know to appropriately screen patients for ACEs, assess for risk of toxic stress, and respond with trauma-informed care, as well as how to participate in the ACEs Aware Medi-Cal program. The training provides CME and MOC credits and is available now at training.acesaware.org. We are very excited to be launching Phase 2 in 2020, where we will be partnering with organizations to provide additional certified and supplemental training opportunities. We have developed a curriculum criteria for certified training opportunities, which certify someone to be reimbursed by Medi-Cal for doing ACEs screenings, which are a little different than supplemental training opportunities that'll dive into different topics. We're going to be planning robust series of provider engagement webinar sessions in 2020, as well as a very robust provider communications and outreach efforts. So we are excited that these efforts are starting to launch, and the RFP is certainly going to be an important part of that partnership work in executing on some of that work. Phase 3, and I won't cover too much of this because we'll be hearing from Dr. Mochtinger at calQIC at the end of the webinar. But we're also excited to have a very deep and high level of engagement in a learning collaborative across the state to help continue to support providers in working on the ACEs work and in implementing ACEs screenings and developing and sharing best practices across the state. So again, we will get into more details from Dr. Mochtinger at the end of our time together this afternoon. To give you a brief overview for the request for proposals, we are requesting grant proposals in 4 different areas: provider training, engagement, communications, and convenings, and we'll be walking through each of those. Here is the timeline. We are accepting comments on this draft request for proposal on Monday at 5 p.m. We will release a final RFP later next week, and then we will be releasing more questions and answers in January ahead of the rounds of responses. The next slide, we have the request for proposal overview grant requirements. And so this is around, what type of organizations we're looking for and what we're hoping to fund. We are really trying to maximize the diversity of provider training and engagement opportunities for Medi-Cal providers and other professionals across the state. And so we're going to be giving preference to organizations that really have that connection with Medi-Cal providers and can help develop networks of care in their communities. And we're looking for a broad diversity of organizations to apply and to co-brand their work with ACEs Aware. And with that, I would like to hand it over to Dr. Burke-Harris to go into some overview of the different individual grant RFPs. Dr. Burke-Harris.
Thank you so much, Hillary. I want to start by talking about what our goals were for designing this RFP for provider training, provider engagement, communications, and convenings. For our provider training RFPs, really our goals were to support the proliferation of high quality trainings on ACE screening, toxic stress management, and trauma-informed care, and also to provide additional certified and supplemental trainings for specific modalities, right? For provider-specific modalities like maternity care, pediatrics, adult medicine, family medicine, etc. And the opportunity here is to certify an existing training. So that's a certification of existing criteria RFP. But we also want to highlight that any training has to include some basic curriculum criteria that have been included by the Office of the Surgeon General and the Department of Healthcare Services. So partner grants will be going out to develop a new training, adapt an existing training, or host a training event. Next slide, please. For our provider engagement RFP, our goal really here was try to make sure that as many providers as possible are eligible for that reimbursement, for that $29 per screening payment by activating our network to make sure that folks know about it, are engaged, and are really building some of that capacity within their clinics, within their systems, within their networks, and also their communities to be able to not only build that expertise and that knowledge, but also build those connections that are necessary. So we're really trying to build a field. And those activities that would be considered for the grant include provider engagement, developing and supporting the network of care, peer-to-peer learning, and white papers that can help to advance clinical practice and be clinically useful tools. Next slide, please. For our communications RFP, we want to make sure that as many providers as possible, as I mentioned, complete that 2-hour training and submit the attestation by July of 2020 so that they can qualify for that reimbursement. And so we want to engage with our partners to reach their members and key audiences, to raise awareness about the ACEs Aware initiative, about the positive impact of screening, of best practices of toxic stress management and trauma-informed care. So we're really trying to really engage with our network of providers across the state of California to share this information, really highlight models of what's been working, what's been helpful, and lift up spokespeople across the state, because we know that there are so many folks who are already doing this work, and we want to lift you up, shine a light on you, and put some resources behind sharing the message and getting the word out. Next slide, please. And then finally, for our convenings RFP, we want to recognize that when it comes to, as we're doing this work, ACE screenings are just the beginning, right? And that it's not just about the screening, but it's also about the response. Some of that response happens in the primary care home or in the healthcare setting, but a lot of that response also may have to happen in the community. And so we want to provide on-the-ground opportunities to train providers, to educate other professionals, to improve collaboration and coordination across our system so that we can build these networks of care in local communities. What's needed in an urban setting like Bayview Hunters Point in San Francisco, where I had my practice, is going to be really different than what I've seen the needs of our rural Northern California communities or might look like, or the Inland Empire, or what the needs are right on the border, right? And so we really want to invest in developing local capacity to really tailor the needs to of response to local settings. And we want to invest in system-wide regional and local sharing of expertise, coordination, and capacity building to respond to ACEs and toxic stress. Next slide. So while we are hoping that these RFPs will be an opportunity to engage and activate our broad set of partners, providers, our networks across the state, as we're doing that, one of the things that's really important is ensuring the level of quality and scientific rigor as we're implementing ACE screening in primary care. And so we've established some guidelines for training content that are important to make sure are covered. One, of course, the traditional adverse childhood experiences, these 10 criteria that were where we have the strongest and most robust data coming from the Kaiser and CDC research. But we also want to acknowledge and we want these trainings to speak to additional risk factors for toxic stress. And it's important that as we're making sure that our trainings are evidence-based, right, that we're comparing apples to apples when we're citing data about risk of disease. So it's important that as we're looking at ACEs and other risk factors of toxic stress, that we are being clear about using the most rigorous science in understanding, for example, relative risk of disease, et cetera. It's critical that we include trauma-informed care, as well as, again, we're not just screening for ACEs to identify, but the purpose of the identification is response. And so we want to make sure that the training content gives clear guidance for primary care clinicians on how to respond to ACEs and toxic stress and how to build resilience. Next slide, please. So specifically for the training curriculum content, there are a number of guidelines that were developed by the Office of the Surgeon General and the Department of Healthcare Services to clearly outline some key points. And these are all, this is all content that is in our current curriculum, Becoming ACEs Aware in California. And this includes trauma-informed care principles, how to achieve them in patient care and for staff, information on ACEs and toxic stress physiology related to the implications for patient short and long-term health, the clinical algorithm, right? While we are trying to broadly activate our network to disseminate the best practices, we do want to maintain a level of standardization and fidelity. So for these RFPs, we're asking for teams to utilize the ACEs-aware clinical algorithm for screening for ACEs and assessing risk of toxic stress physiology, addressing the ACE-associated health conditions by supplementing usual care with education about toxic stress and how to regulate the stress response, treatment planning and follow-up, supporting resilience, identifying, recognizing and preventing vicarious trauma and burnout, and finally, information on how providers can participate in the ACEs Aware initiative. And I want to recognize, while some of this information, there are so many folks who are already screening for ACEs and already implementing this work. For example, the clinical algorithm on how to screen for ACEs and assess for toxic stress physiology, and the list of ACE-associated health conditions are new, as they've been developed by our clinical advisory subcommittee. So anyone who would like to have a copy of the current ACEs Aware curriculum materials, please feel free to shamelessly borrow, steal. We're not asking you guys to reinvent the wheel. You can just email info@acesaware.org, and we'd be happy to send you a copy of the ACEs Aware curriculum, and you can take the key components about assessing for toxic stress physiology and ACE-associated health conditions, and put that into the format that works best for your clinical setting, specialty, your team, whether it's medical assistants, nurses, community educators, right? As long as we're all working off of a same evidence-based reference information. Next slide, please. And finally, for our convenings, what we'd like to see for our convenings are, number one, provider training, and of course, with priority for provider trainings that provide continuing education, right? But we also want to see that local and regional stakeholder engagement. And there's more in the RFP about this piece. We want to be bringing together our network of care, both within our healthcare system and our partners in the community, so that we can not only screen, but also effectively respond to mitigate ACEs and toxic stress. And we also want to ensure that these convenings have a strong plan for communications and outreach. As I mentioned, we want to make sure that we're having regional flexibility to identify the approaches that work best for your local communities. So we will be hopefully making grants, awarding grants in a range of specific regional areas so that we can activate that local community and develop that network of care. Next slide. So I'll hand it back over to Hillary so that you can lead the rest of the discussion.
Great. Thank you so much, Dr. Burke-Harris. So we are now going to launch into a discussion. The Surgeon General has convened a trauma-informed primary care implementation advisory committee to help provide guidance and input on this process moving forward. So we're going to start today with a discussion among the advisory committee members to get their input on the RFP before we move to a public comment period. So we'd like to start by discussing the provider training RFP, and as Dr. Burke-Harris mentioned, there's two different components. One is the certification of existing criteria as meeting, or of the existing curriculum as meeting the full curriculum criteria to be certified as an ACEs Aware training. And then there is the partner grants RFP, where we will be providing grants for folks that want to develop additional trainings that are either meet that certification and are a certified training, or are a supplemental training that don't fully meet the criteria, but maybe do a deep dive into one of the areas. So just would like to open it up. We've unmuted members of our advisory committee. So if there's anybody who wants to jump in on this, we are excited to hear from you.
I'll go. Can you hear me? This is John Goldfinger.
Great. Thank you, Dr. Goldfinger.
So I'll say, first of all, I'll just give tremendous kudos to everyone involved in this groundbreaking initiative. It's very, very exciting, and I'm thrilled to be supporting it. I think when we talk about engaging and really training providers or providing education, one of the great strengths that you outlined is the diversity in the content and the focus, as well as the provider and professional types. So that really is a trauma-informed approach to recognize there's no one path to treatment. There's no one exact professional type. So I really want to applaud that. And encourage everybody to really think broad and diverse about what types of individuals in your communities. And so to that extent, I would say maybe folks could, in addition to the ones listed, kind of the more traditional healthcare professionals, think about community health workers, think about public health nurses, think about even peer groups that might potentially benefit from it. Think about early child care professionals, educators, other professional types. I also think when it comes to the training content, and the content outline is tremendous, I would also encourage the state and everyone on here to incorporate cultural competency, which I believe there's some aspects of it in the RFP, but I would flesh that out further for us to recognize that cultural competency includes our understanding of our patient's culture and how it influences their decision, but also it includes how we may perceive or even misperceive or allow bias to come into our practice based on our cultural beliefs and how our own cultural beliefs may differ and may influence our care. And I think trauma-informed care, while cultural competency was not part of the original SAMHSA definition, I would highly suggest that cultural competency, even how different cultures think about child rearing, child abuse, neglect, what is nurturing parenting, for example, mental health, substance misuse, violence. There's tons of data suggesting there are significant cultural differences in what people believe about what's right, what's wrong, what's good, what's bad, what have you. And that can only really bolster people's trauma-informed practice if we have content about that competency.
John, this is Dr. Burke-Harris. Thank you so much for that. It is one of the criteria, but we just missed it on the slide. So thank you for pulling that in there, because it absolutely is one of our core criteria.
Hi, this is Bridget McCaw. I'd like to offer a couple of comments. The current training, one of the things that I like about it is it's a blend of kind of traditional content presented by slides, but then it has case-based approach to learning, also has a video that's part of it. And I would like to encourage people to consider submitting various learning techniques for this particular provider training RFP. I think there's a lot that can be gained by having case-based approaches, having video demonstrations of really best practices in talking with patients, having videos with patients talking about their experience, clinicians talking about how it's made a difference in their practice and how they do it. So I think having a variety of different kinds of training opportunities, in addition to the typical kind of lecture modalities that we're familiar with, will be good to cultivate from this RFP.
Great.
Hi, this is Cindy Keltner. Sorry, did I interrupt someone? I agree with Bridget. The other thing that we've done here at my organization to try to engage providers is to to use a lot of different modalities as she suggested, but one that I haven't seen mentioned is to chunk the information into podcasts. And our providers really like that opportunity because then it's, short to the point, and if they want more information, then there are links for them to go back to and get more information. But it's something that they can listen to in between patients or at lunch at the clinic, or when they're driving in or driving home, and they found it really helpful to help them sort of get some basic understanding of different topics.
Great, thank you.
This is Tanya Dansky. I'm with Blue Shield Promise Health Plan, one of the Medi-Cal managed care plans in LA and San Diego. And I think from our health plan perspective, something that we're talking about is to collaborate, because many providers contract with multiple Medi-Cal plans. And so to find the best way to remind the providers to do this, but possibly not, over remind them if they're contracted with, say, 5 different health plans.
Great, and I think that actually leads us very nicely into the next topic, which is the Provider Engagement RFP, and to think about how are we, so that was really helpful feedback in thinking about what types of training opportunities should be made available from different modalities, targeting different types of providers and non-providers, and also ensuring cultural competency. But in terms of engaging providers around this work and helping them think about how are they going to incorporate this into their practice, what are the best practices for doing so, and learning collaborative activities. Wanted to see if there was input on the types of engagement activities we'd outlined in the RFP, and how we should be thinking about that section of the RFP document. Anyone on the advisory committee wants to jump in?
So John here again, I'll lead. I think one of the things I really loved was your guys pointing out that integrating different screening types may be a challenge for folks. And so I would encourage people to kind of get in the weeds a little bit around algorithms for how do you incorporate ACEs, which will include recommended best practice screenings of specific adversities. So for example, in the RFP, you rightly pointed out, as Dr. Burke-Harris and I have talked about in the past, that maternal depression will be one of the earliest ACEs, but there are AAP and ACOG recommendations and AAFP recommendations to screen universally for maternal depression. And so I think it's very important to think about how do we integrate and incorporate more specific screening, which will have may have more questions to it for any one ACE, and that would be including depression, anxiety, substance abuse. In a wonderful organization I support, Family Planning Associates in Women's Health, we've now been screening for ACEs using the PEARLS tool recommended. And one of the things we recognized is if we use a different question set for partner violence, that might be a challenge. So we created an algorithm where we're actually going to use the PEARLS questions that reflect on partner violence. I think the original PEARLS tool, it's question 9 and question 9. So important to think about that, as well as other screenings that aren't necessarily, inherently embedded within the ACEs screening tools. Child development. How does pediatric practice, optimize what's already been an uphill journey? I'll acknowledge, for screening for child developmental risks and now behavioral risks and social emotional development. And so we want to really be really in the weeds or really intentional about the types of algorithms we develop. And I'm hopeful that we can all share those things across the state so we can come up with the best possible workflows.
Great, thank you for that comment.
This is Tanya Dansky. Again, I can't be quite as eloquent as Jonathan, but a piece that I was thinking about is, again, I am a pediatrician, so I've seen lots of emails and notifications from various AAP chapters and local, my own sort of trade organizations about this topic. And so I think that's something to keep in mind, is that, we all wear different hats in the healthcare system, and that we want to get the word out as much as possible and realize there may be overlap with other folks' efforts on the topic, and just to see how we can coalesce those efforts as much as possible to ensure that any provider who takes the time to do some training related to ACEs is sure to do, if they're a Medi-Cal provider, that they're sure to do this training so that they, get their credit and get registered.
Thank you, Tanya. This is Dr. Burke-Harris. I also want to include, to your point, activating and engaging, the whole goal of this RFP is to activate and engage our existing infrastructure. And all of the work that is currently happening. So aligning and collaborating is something that we're really strongly encouraging for this RFP process. But the other thing, to Dr. Goldfinger's point, is that we also want to, I also encourage folks to think about clinical utility, right? And, just for myself, also as a pediatrician who's been, doing ACE screening now for over a decade, one of the things that I found was that it really was incredibly helpful for my clinical decision making in terms of understanding if a patient may, a patient's presentation may be impacted by toxic stress physiology. And so I also want to encourage folks to think about how the ACE screening tool is not just a history taking tool, but also a clinical utility tool to help us provide better care.
This is Bridget McCann. As an internal medicine doc, I'd like to follow up on your comments, Nadine. I was thinking about some sort of additional engagement activities and places that we ought to think about encouraging people to apply for the RFP, and that would include reproductive health services, as John mentioned, Planned Parenthood. School-based health centers are another place where thinking about the role of ACE screening and education could be helpful. And then there are specialty parts of adult medicine where I think this could be where we could learn a lot from the kinds of engagement activities that people propose. For instance, sometimes when people come into oncology, those who have a history of trauma have a lot of difficulty thinking about the intrusive efforts that may be part of their treatment. People who are considering bariatric surgery, people who have chronic health conditions that are not well managed. There are some niches in adult medicine where understanding about that history of trauma and what impact it has had and may have on people's engagement in care could be very useful and be very empowering for adult medicine doctors. So I'll put that in as a contribution.
This is Eddie Mochtinger. Can you hear me okay?
Yeah.
I would just like to add, I see throughout the RFP opportunities to engage community partners in the response to adversity. And in my particular practice, that has been crucial. And in the convening section, there's a very specific call out of opportunities to convene medical providers and other Medicaid providers in the community who may be available for mental health, substance use, or other services. In the other categories, in partner training and provider engagement, there are some allusions to partners, one in provider training about referrals to community partners, and then one in provider engagement under network of care that includes community providers as targets of the education. And I wonder if we can call out specifically opportunities to develop partnerships specific trainings about how to do that, exemplars of partnerships, and maybe even opportunities to create those partnerships as part of the training.
A wonderful idea. Thank you. Yeah, I hope folks do see throughout the RFP, and should have mentioned, you know, we did develop sort of a deck to walk through, but the RFP itself is a good 20 pages, and so we definitely appreciate the thoughtful review, and that was a very helpful comment.
And this is Dr. Burke-Harris. If there's just one thing that I can add, it's a recognition that, you know, while we had an amazing clinical advisory subcommittee that developed our Becoming ACEs Aware in California training curriculum that's, you know, now live online, we recognize that this is really about tapping into the wisdom and experience of our broad community of providers to be able to come up with really, you know, innovative approaches to addressing ACEs. And we're really looking at it from a, this kind of 360-degree approach. So I really just want to encourage folks to think about what that looks like. Think about, you know, what providers we need to engage, and what are the key aspects to be able to move this field forward, because this is the whole goal. All of the recommendations that I've heard today just make me so excited, and it makes me feel like, oh my goodness, this is really happening. The wisdom of the community is really going to come to bear, and it's just so exciting. And you know, we can't wait to read all the fantastic RFPs.
Great. Why don't we move to the next RFP, the communications RFP. So we're very excited about this. We know this is, and Dr. Dansky, I think you alluded to it a couple of times. We do think it's really critical to expand awareness of the trainings and of the ACEs Aware program, and to start to, you know, help providers understand what resources are available to them through the ACEs Aware initiative. And so we're really excited about the communications grants and wanting to, you know, as you said, Dr. Burke-Harris, tap into the existing infrastructure and how we can help increase the flow of information about all things ACEs. So just wondering if folks had any specific feedback on additional types of communications activities we should think about including in the RFP, and if there's any feedback on sort of the types of providers or that we should be, you know, thinking about targeting or prioritizing.
Bridget McCoggan, I think it would be wonderful to make sure that we're getting the voices of different members of the healthcare team and using those in the venues really across the state. And I think about ACEs Connection as a place where you can feature short stories of staff experiences with screening and connecting with patients. As well as patients as well. I think if we have really a broad frame for who can speak to this, and then how we create different modalities, like for instance, the podcast and so forth, and then think about where there are multiple interfaces, whether it's in the professional organizations as they gather for different kinds of communication, if it's through the California Medical Association, if it's through the local medical associations. I think there's a variety of different places where short, targeted, inspirational messaging can help echo what it is that we're trying to do across the state.
Thank you, Dr. McCaw. That's very helpful feedback. Anything else
This
on
is
communication?
Nancy Goller, and one, I just want to add to the accolades. I had a little trouble coming off mute earlier, and so I wasn't able to make earlier comments, but my peers made so many amazing ones. I don't really have much more to add, but I do think one of the places where communications, and it's probably perhaps not in the very first phase, but I actually think that the people who will drive this are our patients that we're taking care of as well. And, you know, we hear stories of our staff and our patients who, as we start asking these questions, as we start addressing these needs, you know, the level of feeling cared for and undoing some of the negative impacts and giving them those tools and seeing them change the course of their lives, I think that we need to include them as we are communicating why this is so important. And so I think bringing in patient advisories and making sure they understand what we are trying to do for the communities, I think we will find some of the greatest spokespeople that we have will be the people that are touched by the fact that we're changing how we're delivering care. So I just think we don't want to lose them in this, and there may be organizations that are more adept at bringing together patients to help with guiding these types of practices and also helping us to learn what's working and not working as we implement further so that we can just take this to those next levels.
That is such thoughtful feedback, Dr. Goller. Thank you. I completely agree. You know, this is so much of a provider-focused campaign, but the reason we're all here and doing this is really to improve the lives of the patients the Medi-Cal program serves. And I think, yeah, we would love to see RFP responses that are really trying to drive and have the patient voice at the center of it. That's really thoughtful feedback. Thank you.
Can I pile on to that? So I think it's member stories, but it's also stories about providers and members, members, I'm being a health plan person, patients, people, children, adults. So it's providers and their patients kind of working together. So real life case studies. I know we shared one early on in this work, earlier in the summer of once ACEs screening was implemented in our clinic. Then, you know, a child was able to share that there was violence in the home and the mom was amenable to help that day and they got to safety. So that was, you know, within the first month of doing screening. So stories like that to help the providers understand, you know, why would we do this screening? How's it going to make a difference? I think are important to document and share.
Thanks. All right, we are going to move on because we want to make sure we've got enough time for public comment at the end. There's a convenings component to the RFP, and just wanted some feedback on sort of the overall approach to trying to drive a lot of local flexibility in developing regional convenings around provider training and developing networks of care.
So this is Cindy Keldner. I think this is really an exciting piece of the opportunities that are out there, and the fact, you know, that you're recognizing that there are differences in the regions and those marketplaces, and how, you know, the support that they might need and the training that they might need, knowing that some are doing work already, that they're, you know, all across the continuum in different areas. I think this is a really exciting piece that may also, even though it's more focused locally or regionally, may also help lift up some promising practices that can still be shared across the state.
Thank you. We're excited about it too. You have feedback on the convening?
This is John.
And then we just, go ahead.
I would just briefly say that I would encourage at convenings to think about how to have the community members' voice there. We've acknowledged or mentioned lots of different stakeholders in kind of the choir, the healthcare stakeholders, but it's very important to have the family voice. And not every community has an organization that represents, the patient or the family voice or the child. And so just important writ large, whoever would be applying to that, to think about how do you highlight that, because when we think about networks of care and care coordination, sometimes we might think we know what's the best way to get people access to services, let's say, if that's a barrier, but we might not. So I encourage folks to think about that.
Great. Thank you.
Bridget McCaw, I think it might be useful for us to spend a little time thinking about whether there are some key organizations that ought to be invited to each of the convenings that are done. There may be some absolutely necessary partners, regardless of what the region is, that ought to be considered for inclusion. And one thought is certainly the people who are doing child maltreatment or child advocacy, whether it's Help Me Grow or First Five, and I think we could do some careful thinking about whether there are some other essential partners that we would want to encourage anyone who has a proposal for a convening to consider in including.
Great. Sounds like a great idea. All right. We wanted to create an opportunity, just if there's any sort of general overall input from the advisory committee, for just a minute or two before we turn to some of the questions we received for public comment. If there's any final thoughts from our advisory committee members? All right, well, I just want to thank all of you so much for participating in the Trauma Informed Primary Care Implementation Advisory Committee. Thank you so much for your time in reviewing the RFP and providing your comments today. This RFP was really developed based on a lot of thoughtful feedback we've already received from the advisory committee, and we really appreciate your partnership and engagement in the work. So thank you again, and of course, as always, feel free to reach out if you have any additional thoughts or follow-up from the discussion. So we would like to open up for public comment at this point. So we've received some questions and feedback through the chat box, and we can certainly go through some of those as well. But we are also happy to, if folks want to raise your hand in the GoToWebinar system, and we can open your line as we go through. We sort of put all of the different RFP sort of questions in one place, so we're happy to take comment on any of these. We will ask, however, that folks try to comment on the RFP itself, as that's what we're really hoping to get feedback on today. So we'll start with LaWanda Wesley, I'm sorry, I misread that. LaWanda, your line is open. Like to...
Hi, thank you very much. I'm excited for this opportunity. When you're talking about essential partners, one of the groups I have to say that I'm an ally to and work in the space of is early learning. And we have those beautiful children with us day in and day out, from from infancy all the way through school age. So I'm wondering if there's a way for us to be seen as a partner. We have a beautiful model in Oakland Unified School District throughout the city of Oakland that we're doing with the funding of the David and Lucille Packard Foundation. And we're collecting research now with Dr. Julie Nicholson, who's supporting our evaluation methodology, and we're seeing promising practices already. So, and we're doing trauma-informed work with our teacher practitioners and seeing the difference in the classroom setting. We see less children being expelled or dismissed from programs. We're seeing teachers engage in self-care. We also see them working directly with parents to engage in the same practices. So this whole approach around whole child, whole family, whole community is being put into action. And I just ask that partners see early learning as an essential part of that work, and the resources that we have started to develop around that work. We actually have just put out a document called Culturally Responsive Self-Care Practices for Early Educators, and also looking at how that work is supporting the children directly in the classroom and practitioners engaging those strategies. And we would love to be a part of even though this is a medical model, we would love to be a part of that work.
Thank you very much. Do you mind just sharing if you have an organizational affiliation?
Yes, my organizational affiliation is Director of Early Learning and Quality Enhancement with Oakland Unified School District, and I also am a co-founder and co-director for the Center for Equity and Early Child Education that was just recently launched. But my primary affiliation is with Oakland Unified School District and engaged in partnership with Oakland Starting Smart and Strong, again, funded by the David and Lucille Packard Foundation. And we're engaged in trauma-informed efforts right now that is about 3 years in, and we're seeing the practices yield positive impact.
Thank you, Luanda. This is Dr. Burke-Harris. One of the things that we're really excited about, and this is the kind of the reason why, while this is a initiative focused on implementation of a screening and response in primary care, it was really important for us to include the network of care and community partners, because we would love to hear from the innovative out-of-the-box ideas of how we create that coordinated continuum of care. And so how, how we want to hear from you. What is the best way for our early learning partners to be part of a coordinated response to responding to ACEs identified in the primary care home?
Thank you. So I think we have time for at least one more public comment. Diane LeBrant, your line is open. Oh, you have dropped off. All right, so Samara, Balemelu, I'm not sure if I'm pronouncing that correctly. We've unmuted your line, but you were muted. Samara, if you'd like to provide comment, just unmute your line. We'll come back to you in a minute. Mandy Taylor, your line is open.
Wonderful. Can you hear me okay? Okay. Reading through the RFP, I was disappointed not to see more culturally specific trainings or providers being called out in terms of getting access to folks, because there are particular providers and particular populations that have higher incidence of ACEs. In particular, we know that our trans community experiences multiple different types of poly-victimization as a part of their ACEs experience. And so I'm just really, and we also know, right, that folks in low-income communities and folks of color in terms of, in relation to their minority stress, and the allostatic load that they carried. So I would really love to see in this RFP a specific call out. And I know I heard one of the community advisory members share a little bit about cultural competency, but I'm not seeing it specifically called out in this RFP.
Thank you. I want to, I spoke, this is Dr. Burkeris. I spoke to it a little bit in terms of additional risk factors for toxic stress, including racism, discrimination, poverty, et cetera. Those are really important. And so we want to see that. We want to see that in your RFPs. We also, and the piece that we called out is really looking at having that be, so that's a critical part, making sure that it's not confounded with the traditional ACEs, but recognizing how do we advance the science and practice, right, by understanding the roles of these different risk factors for toxic stress. I think it's absolutely critically important. So thank you for that point, and we will strengthen the language of the culturally specific trainings and responding to patient racial, cultural, national, and geographic and gender identity.
Thank you. That's definitely a critical component we will incorporate. Unfortunately, we want to make sure that we've got a little bit of time for Dr. Mochtinger at the end. So here's just a reminder on the timeline and where to submit comments on the RFP. So if we did not get to your comment, I apologize. We have taken in all of the comments submitted through the chat box function on GoToWebinar, and we will include those as well as any formal comments submitted online. And with that, I am really excited to introduce Edward Mochtinger, Professor of Medicine and Director of the Center to Advance Trauma-Informed Healthcare at UCSF, who will be leading the California ACEs Learning and Quality Improvement Collaborative. Dr. Mochtinger, you should be good to go.
All right. Thank you so much, Hillary. I'll be co-directing this initiative alongside Professors Onda Kuo, Margarita Lightfoot, and a truly outstanding clinical and implementation science team at UCSF. And so our goal is to integrate screening and response for ACEs in safety net healthcare settings in a way that enhances connection between patients and providers, helps connect patients to services they want and need, and leads to better outcomes and experiences of care for all involved. And to accomplish this goal, DHCS and the Office of Surgeon General formed an innovative partnership with UCSF, who has world-class clinical content and implementation science expertise, the Center for Care Innovation, CCI, who has over 20 years experience providing technical assistance and training through peer learning collaboratives for safety net organizations, and the RAND Corp, one of the preeminent California-based nonprofit organizations that focuses on healthcare innovations and evaluation. And together, next slide, we will facilitate an 18-month statewide learning collaborative of pediatric and adult clinics in 5 California regions. And by participating, clinics will receive on-site and virtual content and process coaching, expert training, peer-to-peer sharing of promising approaches, challenges, and solutions, site visits to successful programs, and funding support. And this learning and quality improvement collaborative will contribute to the collective wisdom about ACEs being developed in California across these many linked initiatives by identifying facilitators, challenges, and solutions to the successful implementation of ACEs screening and response, and by creating scripts, tools, algorithms, and other resources to inform the next phases of the California ACEs initiative. For this particular initiative, the RFA will be broadly released at the beginning of March, with responses due at the end of March, with a cohort announced by the end of May, and end of April. And there is a contact for any questions you have, and this information will be linked on ACEs Aware website shortly. Thank you so much.
Thank you, Dr. Mochtinger. We are very excited to see the California ACEs Learning and Quality Improvement Collaborative launch in 2020. So just to wrap up, and we are right at time, thank you again, everyone, for participating in today's call. We hope this was helpful and informative. We are very excited to see a lot of responses come in. Any further comments on the RFP are due to us Monday at 5 p.m. At that link at the bottom of the slide, you can find both the RFP and how you can submit comments on the RFP. We will release that final RFP next week, Thursday, December 19th. We're going to be releasing a little bit more information. We've gotten a lot of questions about the RFPs, and we think we'll, as questions come in, early January, we will then release answers to those questions to give you more information before the first round of responses are due January 31st. And we'll do a second round of responses on March 31st. So thank you again, and we look forward to continued partnership around the ACEs Aware initiative. And extra thanks to Dr. Burke-Harris for your leadership on this issue. Have a wonderful afternoon, everyone.
Thank you, Hillary.